Welcome to Dental Sleep Medicine Speakeasy. This is our inaugural session, and being a newbie at this, I only turned on the record button halfway through. Nevertheless, here are the slides from the intro and then the rest of the recording. I think we have some reasonable content on here. Please join us on Wednesday afternoons from 3 to 5, and I'll promise to hit that record button at the beginning of the session next time. I'd like to start off by thanking our many sponsors, not only for sponsoring our programs, the in-class programs and online programs, but also because of the wonderful role they play in helping to up our game and continuing to evolve and provide products for us to use, appliances, tools of the trade that allow us to do so much better a job than we could do 10 years ago. And their evolvement in the products that we use is what helps us better help our patients today. So thank you. A shout out to all of them. Just like being here, except you're not, looking for that silver lining in the cloud. Bite registration techniques. There's so many different things being done out there. And everything from sophisticated three-dimensional maneuvering equipment to a basic wax bite plate wax used to take a bite at a particular vertical, or even a golf tee. Everything under the sun is being used. So let's just do a little quick review of the literature. Vertical dimension opening. Well, we know that increased vertical is associated with increased respiratory resistance and can lead to increased collapsibility. Now, back in 2002, increased vertical did no impact at all on efficacy, didn't improve things, and minimal vertical seemed to be more comfortable for the patient, which is the landmark paper that everybody hangs their hat on. However, that same year, another paper was published. OSA is more effectively treated with increased VDO. However, nobody references that paper. Came out of a much less influential lab and author, and so nobody talks about that one. The Petsis paper is what everybody refers to. Effective VDO on efficacy is unclear. Okay, this is Kathleen Ferguson's paper from 2006, and it's still unclear today. So little effort has been put into evaluating vertical in the literature. Now, we have down Lewandowski's work. Males, 70% improved outcomes while sleeping supine with a high VDO. Okay, now for females, 50% had an improved outcome with a lower VDO compared to a high VDO. And in another paper, higher VDO increased airway size and reduced OSA compared to low VDO. And these are the papers that Dan used to help substantiate the development of the Apnea Guard product. So about advancement, optimum benefit was 70% advancement, no benefit beyond 50% advancement. Support for mild degree of mandibular advancement, support for high degree of mandibular advancement. Now, the matrix validation study shows efficacious positions ranging from about 35% of full range of protrusion all the way up to 100%, and everything in between. And 50% of the people were over 70% advanced, and 50% of the people were less than 70% advanced. So we can see that there's really no set rule that applies to everyone. Now, when we look anecdotally, we see appliances made at all different levels. This is an old slide of mine that I created back in about 1999, 2000, and discussing the vertical issue and the fact that appliances are made at all different verticals, and yet everybody's saying the vertical needs to be kept to a minimum. Well, you'd think that the appliances that were made at a higher vertical would pale in comparison. Yet there is no superiority being demonstrated in any particular vertical or appliance. So this, makes it questionable as to whether vertical needs to be at a particular value for everyone. This was also published very early in the game. I think 2001, Don France published this little case study. 3 millimeters makes a difference between success and failure for this particular patient. And this situation, I was at that time, this was circa 1999, very early in the game. playing with vertical with the silencer appliance by swapping out pins. And in this particular patient, he was advanced to his position 5, still wasn't on the money, had too much in the way of ODI. At that time, I was using nocturnal oximetry, not HST. And we decided to send it back to the lab. I went through the lab fee of having the plate reset so that he could advance further. Of course, the silencer only provided for about 1.8 millimeter advancement at a time. It's a distance between each hole. So, going one position forward meant going almost 2 mils forward. He couldn't tolerate it at that point. He was way too much for him. So we decided to swap out the pin. And we went from a 6 millimeter pin to a 9 millimeter pin. And look at that. It normalizes oximetry. Okay. Now, this is unpublished data on a study that I was doing to try and validate the use of pharyngometry as a protocol, part of a protocol to optimally calibrate an appliance. What I can tell you is that net results is that it didn't matter at all. There was no statistical significant difference regarding the acoustic protocol that we were following versus the usual and customary protocol we're following. But that's not why I'm showing you this slide. I'm showing you this slide because in the acoustic group, we ended up with a good number of the patients having the 9 millimeter placed, the higher vertical, because the acoustic showed us that was the more optimal position. Interestingly, out of the 8 patients, 6 of them were effectively managed at that position. If a higher vertical was detrimental, you wouldn't expect that 3/4 of the patients put at the higher vertical would actually succeed with that vertical. It just sheds a little bit of light on that. And we can see from a 5 millimeter pin, 7 millimeter pin, 9 millimeter pin, position 2, 3, 4, and 5, there was successes and failures all over the map. Okay, so is it about just vertical? Is it about just advancement? I don't think it's about either of those just. I think it's about jaw position. Now we talk about phonetic bite, dangers of bad associations. For years, I dismissed this technique as being like, this is crazy. How does this thing even, I'm going to say, effing work? Well, I bumped into a guy I didn't know at the ADSM. And he started chatting with me, and he mentioned to me he uses a phonetic bite, and these are the exact words I said to him. Does that effing thing even work? Of course, took a step back, and then he went on to explain to me that's all he uses. And I said, look, the only thing it's associated with is this paper published on how it shows improvement in acoustic pharyngometry measurements of the airway, which has never been validated to be related to any HST or full in-lab sleep study results. So, how can it possibly, there's no evidence. And I said to him, look, I'm going to send you a spreadsheet. Go back and fill it out with 20 consecutive patients. And I'm going to fill it out with 20 consecutive patients using the usual and customary approach with a George gauge. Any device would have done, right? And let's see what happens. Well, interestingly, there was no statistical difference in his outcomes versus mine. And then what we did is we went a step further, just out of curiosity, and said, okay, let's get 4 different offices using the phonetic bite, 5 cases each, and 4 different offices using the usual customary and a George gauge, 5 cases each, and let's see if there's any difference. And once again, there was no difference in outcome. So these are 2 different bite registration approaches compared to final results, home sleep tests, in-lab sleep tests. There was variation there. Now, this was never meant to be a controlled study. And so one could very easily criticize and dismiss these results because it's not a heavily controlled study, different clinicians, different protocols, different appliances, yada, yada, yada. It was only really meant to be, let's take a look and see what happens. But we thought it was so meaningful that for the first time, there was actually documentation that the phonetic bite actually does result in a good outcome when compared to actually tests, home sleep tests, in-lab sleep tests, the same type of criteria we use for other alternative bite registration methods. I thought, well, let's see if we can't get this published. And so we did publish it, actually published this year, retrospective comparison of the George gauge registration and sibilant phenome registration for constructed OSA oral appliances. And really what it's meant to be is a pilot study. More work needs to be done to see whether, okay, it works. Does it result in an appliance that's kinder to the patient, one that perhaps results in fewer side effects, one that results in maybe better patient acceptance? We don't know the answers to any of that. And this paper definitely does not even pretend to try and come close to talking about that. It's really, really documenting that the phonetic bite ends up with a similar result to what the George gauge bite, usual and customary protocol, ends up with. So we have a variety of different products available, providing different verticals that allow us to advance the jaw. You just saw the George gauge, and here's the Pro gauge, and then we have the SOM gauge. There's lots of really good tools available that allow us to advance and have different size bite forks and have varying verticals depending on what our protocols are. And something relatively new. The Apnea Guard's been around for several years now. I never really put much thought into it. I didn't really see the value, a little bit bulky, and I didn't, it wasn't going to fit into what I did. But the Apnea Guard reimagined, once the walls are removed, I could see a value here. And it's something that we've been actually doing in our practice since December, routinely for patients. And we're following this. I'm keeping the data, and we're going to see what the outcomes show. Now, what am I talking about here? So you use polyvinyl putty, and you fit the tray. You establish a vertical based on phenotype of the patient. So a bigger male is going to have a higher vertical, a smaller female is going to have a lower vertical, and there's a middle size also. And you establish which level of protrusion you want to use. You want to start conservatively, you want to start at 50%, you want to start at 70%. This is personal. You can decide yourself what you want to do. You take the bite registration in the mouth, while this is in the mouth, by scanning the bite after you've taken an intraoral scan. So obviously this protocol requires you to use an intraoral scanning device. Then you send the patient home with the device and with instructions on how to advance. So in essence, you're initiating oral appliance therapy the day they get their impressions taken. So that 2-3 week period while they're waiting for their appliance to come back from the lab goes from being dead space to being therapeutic time. So by the time they return to actually get their appliance and have it delivered, well, they may have advanced themselves 3-4 mils. And of course we explain to them what to look for and what to advance until this happens or that happens and resolution of this or that. And at the end of the day, when they come in to pick up their appliance, if they've advanced themselves 3 mils, you take their custom appliance that just came from the lab and you advance it 3 mils and you deliver it. So without missing a beat, you started initiating therapy the day you took impressions, and it flows right through to the actual appliance. So scan impression and bite digitally, wear the Apnea Guard while the custom is fabricated, advance slowly to target protrusion, transfer to protrusion to the custom on delivery. Now, as I said, I have been using this protocol since December, and I'm creating a list. We're going to see, what the data shows, and I can tell you a certain percentage of patients have a difficulty wearing it because of the bulk or salivation and so forth. But the majority of the patients seem to be tolerating it well and actually gaining benefit from using this system. So once I have a larger N number, I'll be able to report back more specific, statistics. Right now it's too early in the game for me to be able to say this percentage of the time or that percentage of the time. But overall, I think this is very promising and provides good value for the patients. And I can tell you, pretty well 100% of patients, when I tell them that they're going to be able to initiate therapy the day we take impressions, their eyes light up, their eyebrows raise, and they're so pleased with that knowledge that they can actually start to look forward to obtaining some level of relief starting that night. So it's a very positive experience so far. Unfortunately, this COVID thing has sort of like stopped everything dead cold. But once we start seeing the patients again, I'm going to continue with this protocol. And in a few months, I'll have some, I think, meaningful data to share with you. So here we have an example of the Apnea Guard. You can see trimming away the polyvinyl on the side and scanning the bite, and the resulting DSAT appliance that was made from that bite registration. Now finally, there's all sorts of great tools on the market. This is a little bite fork that fits into the George gauge that's put out by Zephyr. Sharkande developed this. And the Airway Metrics people also have developed a little bite fork that is amenable to scanning a bite registration. And you can see in the middle set of pictures there, the Apnea Guard process. And of course, I think this is also something worthy of mention. There's a bite fork developed by the Oventus people. And what it does is help ensure that you're getting a 5 millimeter interincisal opening right throughout the arch. And this is a flexible fork that stiffens up once you have the bite registration material in there. And I like using it. I really think it was well thought out, and I use it quite often when I want to have that much opening. And before I started on this Apnea Guard trial that I've been doing. So at this point, we're going to move on to the recording from the session of Speakeasy that just occurred April 8th. And thank you very much for listening, and look forward to having you participate in future Speakeasy programs.
This conference will now be recorded.
I forgot to turn that on earlier on.
Oh yeah. Well,
so we're only going to have that.
Oh,
that's
we're
gonna do it again.
That's disappointing. Should we start over?
No, we're good.
So there's a lot of people. There's a lot of people here that treat sleep, and there's a lot of people are telling them there's an entire association in the United States that claims that you can't treat sleep. You should be a TMD expert to treat sleep. There are a lot of people who feel that way. A lot of people who I think overstate the role of joint and joint damage and the risks to patients. And I don't think it's fair to those people, honestly, who treat sleep to have it overstated, or fair to our patients to have it understated. So I think putting it in perspective is really important. And one of the things I've learned is that there are people like John Viviano who has no interest, like many of the people that are here as I look and I know so many of you who treat sleep and don't have an interest in treating significant chronic pain the way, David, you're reporting. And trust me, you and I have the same thing. I can tell the same stories about patients and their complaints, and how we take histories, and the role of migraine, the role of various headache patterns in their histories, and all that. But I think it's important to tell my friends that are treating sleep that they're doing a really good service, and that they don't need to have the temporomandibular joint background. And in fact, many of the people that have the temporomandibular joint background have the background in a lot of cultish theories that were developed in the United States in the 70s, 80s, and 90s that have no science background whatsoever, that have no real history, that have this empirical background of and bodily evidence of experience of bringing them their patients to success. And there's a reason that the AAOP just recently sponsored and successfully got a pain management, orofacial pain management specialty in the United States. And what we're going to see, hopefully, is a lot of this theory and cultish works in my hands concepts are going to go away over time as the universities take over using good evidence and good controlled studies, and start to have an effect on the kind of work that should be done. And yes, there can always be off-label work done, and there's not some really good work done. But so I hear oftentimes people say, well, if you're doing sleep, you should. Nah, David, you didn't say this, so don't. If you're doing sleep, you should know where the condyles are. You should take X-rays every time, and you should know where otherwise you're treating blindly. And even treating joint pain. Don is on here, and Don and I are colleagues and ran a practice together for years. And Don's now running my practice, and he'll tell you that the vast majority of patients that he sees with severe joint dysfunction and joint pain, it is not even in the model as dictated by good evidence-based science, often necessary to take radiographs, to take images. That joint position isn't critical. That in the vast majority of time, well, even if there are arthritic changes, that's not the critical factor in the pain management, or even the factor that controls our treatment decision making. I've heard of so many times, well, if you're going to you wouldn't treat a tooth without an X-ray, and you're damn right you wouldn't. You wouldn't treat a tooth without a bite wing. But that's not, you wouldn't treat a knee. I wouldn't want somebody treating my knee if you didn't take an X-ray. That's right. I would want them to have an image. The temporomandibular joint may be different. You know, you're talking about a arthritic glycomoid joint. You're talking about a joint that's totally different. We're not talking about the whole ligament structure. The whole nature of that joint is different, and the pathology is really unique to it. And for years I thought, well, I took films all the time, and then I stopped taking them and found that they really weren't affecting my treatment decision, which is fascinating. Then I get a call from a guy named Steve Scrivani, who many of you know, who was teaching at Tufts, or eventually ran the craniofacial program at Boston, Mass, and who's written several books in pain management and joint. And he said, Barry, I'm interested in what you're doing, and I'm going to come to your office. And he comes to my office, and he spends the day. And all of a sudden, I wake up that morning. I think, holy shit, I'm in trouble. So I'm going to see all these patients. I'm not taking X-rays on these patients. And long story short, the first patient I saw was a patient with joint pain with sprain, which is most of the time where our joint pain comes from, not pressure on the retrodiscal tissue. And we sit back and we go back to my office, and Steve sit there and says, "Oh, that was really good. I really interesting. I'm interested in your appliance therapy. It's not exactly what I would do, but the whole concept's excellent." And this happens for 2 or 3 patients. And finally, a 4th patient comes, and it's a young patient with a disc displacement with reduction. And I think, okay, this would be great. I'll get an MRI and find out just where the disc is. And I said to the patient, we're going to get an MRI, and we're going to find out where that disc is. And we walk back to the room, and he looks at me and he says, "What the fuck do you need an X-ray for? You know the disc is displaced. Immobilize it. Do the immobilization procedure. Get it done." So what I'm saying is that theory about you wouldn't treat a joint, that you're doing something wrong by treating a joint if you haven't had a film, is at least questionable, and even more so, I would suggest, for sleep.
Thanks, Barry. For some of you who maybe have joined late, I just need to clarify that I hope I didn't leave this impression that I wouldn't treat without an X-ray, but because I already had one for many years before our profession woke up to the concept of sleep, I do use it regularly, and that's probably why I was able to get to the point where I would treat almost anyone, and most successfully for the bulk of the patients in the severe category. Be what you think about whether AHI is right or not. That's the only accepted measurement that medicine talks about now. And finally, by this time, some of you will have realized that Barry and I would appear to be fishing from different sides of the boat in terms of what we're talking about, but we both have mutual respect for each other and our lifelong dedication to helping our patients. I was invited to this meeting by John, who I work with closely, who in fact is our preferred educator in Canada for my sleep academy. And he will admit that he didn't know what phonetic bite was. He clearly admitted today that he thought this was the Bermuda Triangle. How sad is that, that we dentists got virtually no training in TMJ at all? Now, I went to school a long time ago before. I don't think we even had paper. I think we used to use charcoal on birch bark. But I'm connected to a lot of my colleagues even today, and my guess is in every dental school in North America, the sum total of TMD, sleep, whatever you want to call it, chronic pain, would not fill a half-a-day curriculum in the whole 4 years. That's my impression. I think it's the same. So we're all very far away from the mainstream, but we're providing very good care to our patients. All I want myself and my colleagues to do is to do it as best we can, knowing that we're actually the leaders in this field, because colleges will never catch up, universities will never catch up, and we all have the opportunity every day in every practice in every city in this continent to give people a better quality of life by giving them one drug that we should all have in copious amounts every day. That's called oxygen. And the more you give it to them, the better. Actually, it's air, and then we extract oxygen. I'm going to have to leave soon, John, because I've got another commitment, but I just want to reoffer, and I think it comes best through your office. I'm happy to share my whole technique. It's in a 500 megabyte keynote presentation, which I gave to our meeting a couple years ago. I showed it to all my medical and dental colleagues. I also have the same thing in a PDF version, which is, it doesn't include the videos. The instructions of how to do it are included in. I'm happy to have you distribute it, John. I don't think you have the video, but I'm sure you have the paper. Because essentially what I said today is, this is what I've been doing for years, and it works. If there are any other questions before I go, I'll be happy to entertain them, but I do appreciate your attention. And I forgot to mention at the outset to my Jewish friends, happy Passover today.
Really? Oh, thank you.
David, thank you so much for joining us. Thank you so much for joining us. If you could email me that document or those documents, and anybody, I'm pretty sure that I actually collect all your emails. I'll find out after the meeting. But if you don't get a copy of that document, I'll send it to everybody. But if you don't get a copy of the document, it's because I didn't actually, the system doesn't capture your emails. I'm not sure. And just reach out to me, john@drviviano.com, and I'll send you a copy. Okay, David, thank you so much. Really appreciate your attendance, and I didn't know of anybody else that was going to be local here that could talk to us about the phonetic bite. So we really appreciate your insights. Thank you.
Thanks, David. See you, buddy.
Okay. Now I'm going to, because it is now 4:13, I'm going to show you just a couple of slides on something new that I've been doing. Something that is literally brand new, and because the device is brand new. So let me see here. It's, I'm going to show my screen. Okay, share that. And let's take it here. So is that showing? That you can see the Apnea Guard there?
Yes.
Okay. So this is the Apnea Guard that, was developed several years ago, maybe I think 7-8 years ago. And I never really, gave it much thought, whatever. It's pretty bulky, and, what am I going to do with it? And then it was reimagined just recently in the last several months, where they, they removed the walls on the side. Now, the clinical utility to me became quite, obvious. If you fit this in a patient, you use a polyvinyl material in there to align it just like you would any other tray, and you adjust it to the bite you want to have the appliance constructed at, and then you can cut away the polyvinyl on the sides and use your intraoral scanner to scan the bite, right? You've scanned their teeth. Now you scan their bite, and you send those files off to the lab to order whichever appliance you want. Want the Avant, want a DSAD, want a DreamTap, doesn't matter. Any appliance you want. And you send the patient home with this device that you used to capture their bite, and with instructions. basically there's a number of different ways you could advise the patient. But say you are starting them off at a certain advancement and you want them to slowly advance themselves over the next 3 weeks or so while they're waiting for their appliance, to the position they stop snoring. That would be one example of what you could do. And the patient goes away. It's like the treatment is starting the day you took impressions rather than the day you deliver the appliance, which could be 3 weeks later, depending on when they're available, when you're available, and when it comes back from the lab. So in essence, when they come back for their appointment for delivery, you take a look, and if they've advanced themselves 3 millimeters, well, you take the appliance out of the lab box, you advance it 3 millimeters, and you deliver the appliance. So treatment continues without missing a beat. So theoretically here, you would be basically fast-tracking the treatment. And for some patients, they're going to be at their optimum position. Their actual custom appliance is going in at an optimum position. Now, I've been using this protocol since early December, and I was getting quite excited because of the N numbers getting up there, but still not big enough for me to feel confident about talking about outcomes and data. And now with this COVID thing, I don't know when we're going to be back at it, to get the N number higher. But clearly, it's going to be one of those situations where there's a learning curve, and some of the things I've learned the hard way that, I have to make sure the retention is adequate, because if it's not adequate, they won't wear it, And I've given the patient an easy out, basically saying, look, we're using this to take a bite. Now, if you're comfortable wearing it, go ahead and wear it and advance yourself. That would be a bonus, because when you come back, we'll basically continue the advancement from there, and it'll fast track things. However, if you're not comfortable or you're having any issues with it, don't bother wearing it. So I'm giving them an easy out. And so what I'm finding is a certain percentage of patients will wear it and they love it. And a certain percentage of patients, could not tolerate wearing it and they don't. It's too bulky. It's too uncomfortable. It was coming off, my jaw's dropping out. And I can't help but believe that a certain number of those things were my issue, that I have to go up that learning curve of knowing how to ensure there's adequate retention, or maybe case selection. If there's just not enough dentition, that it's not going to retain. It's not going to work in this particular case. But nevertheless, it's not expensive, and you use it to take the bite, and it's a bonus if they can actually wear it all the way through. Once I do enough patients and I have a big enough N number that I feel more confident about, what percentage of the time this tends to happen, then I can share that data. But right now, I just thought I would share it because this is brand new. I actually don't know of any other office that's been doing this. So I'm excited to see it. I want to get more patients done before I can say more about it. But any thoughts or any ideas on this from the group?
Is Dan still on? Can he talk about it? Dan, are you still there?
Yep.
Dan Lewandowski?
Yeah,
I'm
great.
here.
Great. Dan, why don't you?
Dan, anything you want to add to that?
No, other than I don't want Glassman chewing my ass out, so I got to be careful.
That's part of the fun.
It's cruel.
A good ass chewing is always fun. Yeah.
Never, Dan. Never. You know what?
He only picks on Canadians.
It's only whatever. Actually, it's hard to chew the ass out of somebody that's as evidence-based and has worked so hard and contributed as much as you have to our profession.
Well, listen,
Dan, I repeat those words absolutely. You've worked so hard, and everything you say, I mean, people may take exception with the fact that, well, they're small N numbers, okay, but at least you're trying to look at data and present data, not just say stuff, which is very much appreciated.
What I'd like to do is just give a little bit of background on how this whole vertical dimension, from my perspective. Keep in mind, I'm not a dentist. I came to this trying to provide some organization around how dentists work, and about 5 years ago, I completely gave up. But I started working with Todd Morgan back in 2007. We got about $1 million grant from National Institute of Health, and the goal was to try and help dentists figure out how to get better outcomes with their oral appliances. And we started the study. We were using the old TAP 2 that had 10 millimeters of VDO, and we were getting great results on men. We were getting not so great results on women. We kept advancing at a 0.5 millimeter and redoing another HST, and we did another 0.5 millimeter. And we kept looking for the sweet spot in those women, and we really couldn't find it. So we finished that group. There was a group of 30, and then we went on and did a much larger study. We did an additional 100, and we switched from the TAP 2 to the TAP 3. And what Keith had done was he lowered the VDO from 10 millimeters to around 5 millimeters. Didn't do any assessment of efficacy because that paper came out and everybody was swinging toward comfort and mouth breathing and all those concerns. And so we started doing the next group, and all of a sudden the women started treating out really, really well, and we weren't getting very good results on the men. And so I kept going back to Keith asking, what'd you do different? What'd you do different? And then he finally, disclosed that he changed the vertical dimension. So in a group of these patients, we refit the lower tray so that the protrusion was about as identical as we could get. And we added an extra 5 millimeters of VDO. And what we found was that in about half of the men, that increased VDO had a pretty substantial impact on HI reduction. In about half, it made no difference. And in about half the females, the increased VDO made them worse. And in about half, it made no difference. So we presented that in Seattle in 2009. And it was also based on me working with Todd, and he'd say, look, I'd advance, and then if nothing else works, then I'd add vertical dimension. And I kept trying to say, well, how do you tell when to add it? He says, I can't really tell. It's all trial and error. So what we did was we worked back through the data and said, well, maybe you should start with vertical dimension, increase vertical dimension in certain types of patients, just as a starting point. And that's when we, took that logic and brought it over to the Apnea Guard. And, Keith took our research and he created the tap gauge or whatever he calls it. And he used, essentially the VDO that we had come up with, and he worked that into his appliance. And so it kind of rippled through a little bit, but I can remember Alan Lowe telling me that it was criminal to add any vertical dimension to a patient. So there's a lot of bias out there, and what we learned and with this data set, and honestly, I'm having a hard time getting it published. I submitted to 2 sleep journals, and they just don't recognize what I believe the impact of the VDO and how it's improving outcomes. They're saying, hey, look, the concept of increased severity and tongue size, it's already out there. They're not recognizing the relationship between increased VDO, tongue size, and outcomes. So I got some good feedback. I'm going to have to redo the stats, but what we've been able to demonstrate is that when you look at tongue size and gender, it's a significant confounder, and it impacts outcomes. And if you increase the VDO based on tongue size, you will get improved outcomes. That's what our data are showing.
And Dan, I want to point out how important what you just said is, and it's unfortunately I don't understand why this is the case, but for some reason, dentistry is looking at a solution without understanding the potential variables. And so there will be those arguing on how to take the bite or where it should be taken, etc. And we're not willing to look, and the only variable so far that's been looked at has been AHI, and an assumption made that the greater the AHI, the more protrusion was going to be necessary. Now, I wish David were here. I don't like referring to what he said without him being here. But David, is David still here? Oh, great. So the suggestion was great, Kay. I'm glad you are. The suggestion is that there are other things other than AHI, and medicine and dentistry starting to understand it. I mean, medicine's starting to understand it. So we're looking now obviously at ODI. And I truly believe that's that's going to play a major role. Where there's a greater understanding of looking at RDI and its possible role and its role in UARS and making that distinction much more clear. So there are and we're looking at, and finally, even sleep medicine got so tied into mild, moderate, and severe that that many of their articles and much of the research is based upon that, trying to identify that in terms of comorbidities, and then finding even sleep medicine is beginning to recognize that there's not going to be a factor that but even whatever the factor is, it can't have the level of importance that it's not just that it's a bad number. It's not a bad number. It's just it's bad that we've given it the level of importance that we've given it and looked at everything in relationship to it. And so the fact that think what Dan's suggesting. Imagine this: actually looking at a series of variables to help us decide on whether or not this is the patient that may benefit, rather than doing as Todd and I did, and everyone did for years, haphazardly look at vertical as the next thing to do when we couldn't get an answer otherwise. And then what do? Do you then retrude and increase the vertical? I mean, there's so many issues, and it was Keith who sat me down many years ago and said, Barry, large tongues, small mouths need more space, more vertical. That's, as we all know, that's his supposed reason that he went to the Dream Tap to get rid of that the appliance hardware in the tongue space. Of course, his lack of a patent and his need for a new patent may have had something to do with it. But and yet, interestingly enough, there's never been any evidence or any study that's done that showed any change in terms of that appliance issue being in the tongue space. So that's another issue. But that's raises such a great point, Dan, and I appreciate that when we see our men and we see the men with the large tongues, that maybe right away we should start thinking about vertical. The other comment I'll make is the low comment, and there is this assumption that if we there is no such thing as pure rotation. We all know that there's automatic translation and rotation when we open the mandible. So that as soon as we open the mandible, that condyle is coming slightly forward. Now, if we bring that condyle forward enough, and this is what David was suggesting, that that it's possible that if we bring the condyle too far past the eminence or too far forward, I won't say past the eminence, because the eminence position is different based on the eminence anatomy. So and the structural anatomy of the ligaments of the temporomandibular joint ligament and the medial and lateral collateral ligaments, and etc. So we can't look at a position and say it can't be in front of the eminence. But the further forward we are in the presence of parafunction, the more potential damage we can be doing, especially to that very, very at-risk lateral collateral ligament. So there's no question that if a further increased vertical will bring the mandible forward in combination with protrusion, now puts that condyle at risk. But I wouldn't say that. But we can't look at that patient if they don't parafunction. That may not be risky at all. And if their adaptive capacity would still be within their limits, then that may be where they need to be, and to help them and not develop that discomfort, and in order to stop their AHI or control their obstructive sleep apnea. And it may be that we want to put them slightly at risk of their joint when we look at the risk benefit, depending upon the comorbidities, when it comes to sleep. You can't simply say, no, it's criminal to raise the vertical and bring that condyle forward out of its safe harbor. I think that's a mistake.
Dan, I think that last point is very important, Barry, in that, finding the optimum position. I mean, the patient might not be able to comfortably tolerate their optimum position. And, maybe an optimum position is going to actually, perhaps maybe put things at risk. So we want to get as close as possible to that, within reason. But, there is nowhere is it written that they're going to be too congruent. It's going to be congruent, right? They may need to be out here with their jaw, but they can't tolerate that much advancement. And so they're back here and they're only have an outcome that's an 80% improvement rather than 100% improvement, for example, And the other thing too is that I wanted to mention is that, Richard Schwab, which I'm sure you all know his name, is a very high-end researcher in Pennsylvania and has done a lot of publications with MRI and so forth. And so in the last few years, he's been really doing a lot of work on the tongue and showing us that these high, it's directly related, the amount of fat in the tongue and the OSA levels, especially in the posterior region of that tongue, right? So, even he, has suggested that that's key, and we need to know more about that, and perhaps making more room for that tongue for those people that have that, and so maybe the obese male, right, the high BMI would benefit from a higher vertical because of that, right?
Right.
Dan, did your data vary for pre and postmenopausal females?
As far as the need for vertical or
your results different? Were your results different pre and post menopausal? In other words, in my experience, postmenopausal women line up more with men eventually. Premenopausal women respond much better to mandibular advancement, regardless of vertical.
I have looked at our data and found that postmenopausal women snore similarly to men as opposed to premenopausal. I have seen that they are less severe HI postmenopausal. I have not looked at the vertical dimension as a factor that would affect them one way or the other.
Okay, thanks.
I think it is worth noting that in our data set, we found that the females with the large fat tongues also had close to significant greater neck circumferences compared to the females with normal sized tongues. They also had significantly greater BMIs, and they simply didn't treat out as well. They had higher non-supine HIs, and these females with at least what we're seeing in this data set, with the scalloped tongues, they just don't treat out that well. Oral appliances, whether they were fitted with a 2 millimeter VDO or 6.5 millimeter VDO, it didn't make much difference.
And was your sample divided up sleepy and non-sleepy by any chance?
No, we didn't have Epworth scores on them.
Okay, so let me ask this. Why did Don ask that question? So Don just asked, were the patients OSA or OSA patients or patients with OSA syndrome? And why would that be important? Anyone? Thoughts? Don, you want to explain that?
Oh, geez, Barry. You're looking at two different physiological phenotypes there. The patient with an AHI of 50 and no daytime sleepiness is a different animal than the patient with an AHI of 30 and can't stay awake during the day. So you've got a different patient in front of you, and they respond differently to treatment.
Which is exactly one of the major factors that we're now looking at in terms of AHI. So and likelihood to respond to therapy. And that is what we're finding is that patient with a phenotype that's not sleepy tends to respond really well, and the sleepy patients are more difficult to treat, and obviously often are those with other significant comorbidities, which is another reason AHI. I always talk about AHI is measuring how hard somebody is hitting you, but it's not measuring the damage that it's doing to you. When we're looking at other issues, we can measure the damage, so that patient that's getting hit only 20 times an hour may have more damage than the patient that's being hit 50 times an hour. And interestingly enough, it's that the symptom of sleepiness has turned out to be a major, something that we can determine, and yet a major factor in determining what that phenotype is and whether the likelihood of them having other comorbidities, as well as them responding to therapy, which is why Don asked the question of Dan, whether, and when Dan was doing the work, obviously we didn't know that, but that's relatively a new observation. So it'd be neat, Dan, if you could go back, if you have Epworths on those patients, you may find another factor in addition to tongue size that played a role. Which
Except Epworth doesn't work very well in females, though. So but men, it would be really interesting to see.
I didn't know that.
Boy, fatigue and sleepiness are two different creatures in females. It's just different.
Gotcha.
John, David here.
Yes, David.
Hi, John.
Yes, David.
I'm not much of a techie, but is this a backwards image?
2D to 3D.
Okay, all right. Because when I held up the other sign, I was thinking, oh my God, it's probably backwards. I just want to add one more part to the phonetic bite, at the risk of dragging this on longer than it should be. The other component to the phonetic bite is it takes a two-dimensional thinking paradigm to a three-dimensional one. Everything I see that's pre-made, with all due respect to all the appliances out there, it comes to you in a rigid appliance that moves you backwards and forwards. If a patient comes with a shortened ramus on one side, for any number of reasons, they're not already level, the phonetic bite lets the neurology of the patient level out that can't and gives you a corrected third dimension. So not only are we going downwards and slightly forwards, but we're also adjusting the third dimension, which is why I talk about it mostly vertical, but also using 3 dimensions.
So I would find that really valuable, David, if in fact guys that were doing 2D as opposed to 3D were running into significant comorbidity issues. But I'm not sure that's the case. So so just to make clear, the 2D versus 3D is the rationale would be to prevent any comorbidities, not to improve the response to OSA, right?
Right.
I think you're right, Barry. But what I'm really trying to present is, I'm trying to present a technique where where we let the patient's neurology make most of the decisions for us, as opposed to introducing some sort of gauge, appliance, measuring device, or whatever. And by the simple use of the phonetic bite, which is something we all learned how to do when we started walking and speaking, that's how I was able to get to presenting, and I'm very happy to share the paper with everybody, universally over 75% reduction in AHI in all, and most of which for cases over AHI of 30. It's a 3-dimensional, vertically only, patient-centered site registration, and basically I just collect the data. I don't have to think about it, and it works very well. And as I say, I'm happy to share that with anybody. I'll send it to John, and I'm hearing a lot of back chatter. So John, the presentation is about 500 megabytes. I'll send it to you by mail if we still have that working in Canada. And I can send you the paper by email.
I'll send you, David. What I'll do is I'll send you a shared Dropbox folder invite, and you can just put it in the folder.
Oh, okay, that'd be great.
You don't have to mail.
I gotta go.
Yeah.
John,
Any other questions?
I think it's just coincidence that I just poured myself a second glass of wine, David, as soon as you started talking. But I think that's just coincidence. Don't take it any other way.
That's the second glass that we see. The rest is under the table.
John?
Now, Glassman came on sucking a straw. He had vodka in that right from the start, so he's ahead of us.
I didn't realize you were invited.
In Canada, we kind of wait till like 5 o'clock. So Viviano is like 19 minutes away, but he's been pushing the limits because it's his show and he can do what he wants. Anyway,
John,
thanks for the invitation.
Who's got something
nice
to say?
See you all.
I'm trying to get in. John?
Yeah. John, this is Jim Rodriguez.
Who's calling me?
This is Jim Rodriguez out in Alamo, California.
Hi.
You're enjoying that wine far too much for it to be from Vancouver Island, BC. Anyway, my observation here is that if you remember back in dental school, and it struck me then, even when I was there, is that we had a prosthetics instructor, Art Kroll, and he was a stickler for exact objective things, and he would say the most retruded position of the mandible, and then there was the inclusion, the Pankey Institute of the colored wax little things that you knock them off, you got a F, and then we had an instructor who snuck into our classroom. His name was Frank Passantino from San Francisco, and he'd say, boys, now that Art Kroll's not listening, just think about where if you took a completely edentulous patient, because now we're talking prosthetics here, and you put that person in the most protruding jaw position and build a pair of dentures, how fast do you think they shove those out of their mouth? Let the patient determine it and take a mush bite. So I think what we're talking about here, we have a certain mentality in dentistry where we were trying to reach some objective, definitive, ideal position. And we know that the anatomy of all these patients is different. Their neurophysiology is different. And I think that all these different methods of taking a bite are really what we're trying to do is help that patient find their own pharyngometric ideal position, because I don't think we can determine it for them. I think we'd have to have the approach and the mentality we're trying to help them find that best position for them that gives them the most therapeutic effect. I don't think that we should have the objective that we have to be perfect for everyone. As like it's been mentioned here, if you you get a 30% or 50%, any kind of improvement at all versus them not doing anything, then we're living in the world of medicine where it's a floating proposition. Even though everybody wants to be perfect, we can't. But dentists have this thing that they got to have an exact position.
That's because of our training, Jim. That's because of our training. That's part of the paradigm shifts we have to do to go from general dentistry
mental
to
shift completely.
medicine.
I mean, I have these people telling me, the idea about the TMJ problems. The reality is, if you had a patient that you're helping and they're having some TMJ pain, it's probably not because of the appliance anyway. But even if they did, they have a choice. They can breathe, open coffin or open bite, that kind of a thing. So I think this is great that we're trying to find the best ways to help that patient, and within different people's hands, maybe, they have different things. But the object's got to be to try to help these patients as best we can, because the alternatives for them, we can't say no. We have to have an exact thing. So that's just my thoughts about that.
Appreciate it, Jim.
Hope is
Anybody else that hasn't spoken want to jump in and say something?
Hope has written to us and said that, and it's something we haven't discussed, and I think it's worth discussing. There's one of the Spear out in has brought on Jeff Rouse in his team, and they're Jeff, as some of you know, as a prosthodontist who speaks the prosthodontic language, and so consequently it works for Spear, and who doesn't himself know much about sleep, and that's not negative. I mean, just the fact. And so Jeff has developed his own technique that they've incorporated, and they're calling it the Seattle technique. I know that it involves some an immediate introduction of therapy with some follow-up testing, but I'm not as familiar with it as I am with some of the others, and I don't know. Hope indicated that she's not well versed in it, but has used it. And maybe can give us some basics as to what Jeff is teaching in Seattle about. Does it involve bite registration? Where to start? And does it where does diagnosis fit into their initiation of treatment? Hope can you enlighten us at all on that?
So if we can unmute your mic, just click on that red icon that's red with a line through it. See if I can do that.
There you go. You
okay.
got it,
Hope you're on. So Hope, you have not entered your PIN number. So are you on the phone then? You're not on the computer? So you want to enter on the phone 226 hashtag and see if that makes a difference.
I bring it up for a reason. I've read about it. I've had some. I know this will surprise everybody. I've had some run-ins with Jeff. What are you laughing at, Mark? I see you. I see you laughing. I've had some run-ins over. You know, I really have trouble with people who make shit up, and so I've had some run-ins with Jeff over the. She wrote. Hope writes, "My Mac's too old, no microphone." So I'm sorry for that, Hope. We would have loved to have heard that. And if there's anybody that knows anything about the Seattle
Excuse
technique,
me, Barry. Hope, if you want to actually go onto the phone and you can dial in a toll-free number, and then you'll be able to speak to us and you can hear us through the phone, if you wish, okay? You just go to that little wagon wheel icon top right, the little gear, and then it opens up. Pick the country you're in. There's a toll-free number. Enter the numbers when it answers, and you're there.
Can you hear me?
Yes, we can. Beautiful.
Oh, awesome. Good. All right. Yeah, tech is not my thing. Okay. Basically, the first thing they address with the Seattle protocol is that probably 40 to 50% of your patients that have sleep problems, if they will learn to breathe through their nose, will actually correct an awful lot of the snoring. So it's posture, it's jaw position, it's airspace, it's addressing all the allergens and the difficulties you're having with breathing. And putting the patient through a pretty strict protocol, which I don't have in front of me, and it's been months since I heard it, and I put a patient through it in January, and it worked pretty well. It addresses teaching a patient to go back to nose breathing, changing the posture of the jaw, the muscle of the tongue, blocking the airspace because you're not breathing out of your nose, you're breathing out of your mouth. So it goes back to the beginning, counseling people, and also I heard you guys talk about, you know, the inflammation from diet, from sugars, from dairy products, whatever it is you're allergic to. So you address all those things first. You find out why they're breathing out of their mouth. Can you fix any of that by sending them to an ENT to improve their breathing? So you start with improving their breathing, and if you can stop there, you've something for somebody, not even put an appliance in their mouth. If you have to go through surgery to improve breathing through the nose, great. Now, if that doesn't work, now you go on to possibly they need an appliance to open the bite up. So you open the bite, and if that, 10, 15% of your clients improve from having the bite open, great. If that doesn't do it, now you advance the jaw. So you use the MyTap appliance to walk them through first, one step to the next until you find out, do they need an advancement appliance? So you're not just treating everybody with one appliance. One appliance because you're taking it apart and you're disassembling it using a little differently than he designed it, I assume, but you're diagnosing as you go along, and it seems like a really great concept because you're changing how you're looking at your patients. So
when does testing get involved?
Well, I always recommend any client that I see that I feel like has a sleep disorder or a breathing disorder, I recommend consultation with their primary care and ask them, have you had problems with breathing? Do you snore? Has anybody ever told you stop breathing in your sleep? And first thing I do is ask them to have a sleep study done and have that conversation with their primary care doctor or an ENT or pulmonologist, whomever. So that's always the first thing we ask for. And then we go from there.
So one of the things, the purpose of today, thanks, Hope, that's very helpful. And I think I'll comment and suggest that one of the things we've learned is that I constantly go back to John Remmers, who laughs at himself when he says sleep medicine is the only specialty in medicine that has one diagnosis and one treatment, and how absurd that is. And obviously that's not the case. There's lots of diagnoses in sleep medicine, but because where the money was in obstructive sleep apnea and not in treatment of restless leg syndrome or periodic leg movement, that was the physicians don't get paid a lot to treat insomnia. But they get a lot with volume with OSA. So looking at all the variations and what we can do. So getting a patient to breathe. So there's something you said about moving their jaw, putting them in a better jaw position to help them breathe through their nose. And and that seemed to be before there was appliance therapy. So how is that done?
You're not changing their jaw position. The concept is that because their nose is blocked, they can't breathe out of their nose. They open their mouth so they can now breathe. And that itself causes a lot of TMJ problems, causes a lot of sleep disorder breathing. That if you can teach them to rehearse breathing through their nose throughout the day, that many people will self-correct just from doing that. Well,
I'm not sure how many are going to. It depends on their diagnosis and the degree of their OSA. But there is no question. It's a great concept. There's no question that we've learned a lot about nitric oxide, about the importance of breathing through the nose. The tape now, the Somnus tape is a big advantage in terms of the micropores, the kinds of other tapes that we were using to help encourage patients to breathe through their nose. Understanding why we want to lip seal and how to get that with an oral appliance has become very, very important to us. So this sounds to me a little bit like rather than go to an oral appliance first, let's do this first and see how much improvement we get, and then move on and eventually wind up with an oral appliance if we need it. And there's nothing wrong with that under certain diagnostic conditions. Certainly, that's not the way you want to approach the patient with severe comorbidities and significant oxygen desats that concern you in terms of endothelial dysfunction and cardiovascular disease. So that's not the patient you're going to approach that way. But for a certain but more importantly, to add those concepts in terms of nasal breathing to what we do, rather than thinking we could just advance patients. That's beautiful. That's wonderful. But don't tell Jeff I said that, because he'll get a big check. Thanks, Hope. Appreciate that.
So we're coming around. It's like 5 to 5. Is there anybody that hasn't spoken that would like to discuss and share how they take the bite in their practice? Everybody's good?
And Mark's going.
Okay.
Mark just. Thanks, Mark. We need your mic, Mark. I don't have your mic. We don't hear you.
Or maybe turn up your volume, maybe. I don't know.
Not sure what it is. I could read your lips, and you said the word problem, but that's all I got.
I don't know. I heard "fuck you, Barry." That's what I'm trying to read his lips too.
Oh, I heard yeah. Then what's that about?
Isn't it?
Can you hear me now?
That's what I thought.
Yes. Yeah.
That's good, Mark. Yeah. Is that what you said?
Words.
So what was I going to say? I've always questioned, there's one school that says keep the bite as minimal as possible. And then the other school that says it's all in the vertical. This has been pretty enlightening. I'm gonna be playing around with this a lot in my office. I've got an old pharyngometer I haven't used in 10 years. I've got airway metric stuff, which I haven't used probably about the same amount
I
of
hope
time.
this meeting didn't encourage you to use either one of them.
Mark, if you want to have listen, Mark, I have spent at least 1,000 hours doing research on the pharyngometer. So if you want to have a private conversation with me before you waste time, I'm just putting that out there for you.
You just answered that question. My point, I bought it maybe 12, 14 years ago. I only spent $8,000 on it, so I don't feel too bad.
Right.
I used to use it as a sales tool. I don't need sales tools anymore. But this is a little enlightening that I'll start playing with vertical a lot more than I ever did before. That being said.
Yeah, thanks.
Yes, absolutely. You know what? It's 4:57. I don't know, guys, but I think this was a success. I had absolutely no idea how this was going to go, and even how the platform would work and everything. But I think we actually got through it pretty civilly. I think the next run is going to be next Wednesday, same time, 3 to 5. And those of you that don't have a glass in your hand, I'm hoping that next Wednesday you do, whatever you want in it. And the next topic is going to be predicting outcomes, right? Predicting oral appliance outcomes. So we'll talk about the different things that are available, and even different phenotyping. And of course, I think Dan Lewandowski has left us, but the Apnea Guard is one of the things that we'll be talking about, along with the matrix and some other things, and anything that you want to bring to the table yourselves. Yes, Mark.
I'm actually getting back to the office next week. I'm booked solid with consults all week because I've been out for 5 weeks.
Wow. So wait a second. That's amazing. That's actually amazing. What state are you in?
Ohio.
Ohio. So you guys are being allowed to go back to work?
I don't have a general dental practice. I don't have a general dental office. Yeah, I'm considering this essential treatment.
Right. Okay. Interesting. Interesting.
As someone said earlier, oxygen is pretty important. Breathing is pretty important.
I agreed. Yeah.
So I come and say no.
Interesting.
I've held off for 5 weeks. I've been out for 5 weeks. I'm ready to go back.
Early to adopt, early back.
Yeah. So.
Well, I mean, most of us are restricted from doing that, so that's why we're having this session at this time. But in the future, if everybody's enjoying them and they want them to continue, we'll pick another time, during off hours when maybe only an hour long or something like that. So that's kudos to you that you can get back there. But be careful, Mark.
There's a big emphasis.
Be careful.
I'll be able to log in. Sorry, Barry, go ahead.
A lot of guys are doing telemedicine now, and the realization, Mark, is that even if you're even after we get to the other side, and who knows what the other side's going to be, but even after we get to the other side, is it possible that maybe 50% of your day can be at your desk or at your home with telemedicine. And the answer is, in a profession like yours, absolutely.
Let me tell you, I did 12 telemeds yesterday. One of my assistants, we are turning over we used to do all our own adjustments in the office. Turned it over to an assistant who's been home longer than I've been away because she's pregnant with twins. She is handling all the adjustments over the phone as far as these adjustments. And, so far so good. But next Wednesday, I'm in for a consult I'm in there maybe 15, 20 minutes max. It'll be less now that I've done telemeds before each patient comes in. So I'll be able to sneak away. I won't have a camera at my office, but maybe I'll take my laptop. But I'll be able to log in during it. But just in case, John, you are recording this? Are you going to put these online?
Yeah, this as well. But about partway through is when I remember to turn the recording on. Next time, I'll make a note to myself to put right from the beginning. So they'll all be archived for you to listen when you can. Absolutely, yeah.
All right.
Yeah.
John,
it's 5:01, folks. Thank you so much to all of you for participating. Barry, did you want to finish off with anything?
John, the earlier subject came up about the TMJ and whatnot. I just recalled that an interesting article study that's done by Alan Moses, and it refers to the asymmetry of the anatomy in these joints. And it might, if somebody's interested, that might be worth to review to give some insight onto this idea of I don't know which side you'd use. So anyway, thank you.
Yeah, I'd be careful about discussion of symmetry on joints and its importance. There's not much symmetrical in our bodies, so it's not a surprise that the joints aren't symmetrical. And to suggest
that's my point.
Yeah,
that's my point.
Yeah, exactly. Well, I don't mean that. I don't. It's very important when you evaluate literature. You look at the author. So in that case, I would look carefully at the author before I read it.
I understand that, but I mean, my point was that we do deal with asymmetry.
Exactly.
That's my point.
Exactly. You're exactly right.
Yeah.
Right. I'm going to sign off. Barry, Chag Sameach, and you'll be sending out, John, if you can, David's his presentation, his PowerPoint, or his PDF. He said he's going to be sending it to you in a Dropbox. Maybe.
John
is he's muted himself. John, can you unmute?
John, unmute.
Elaine, can you take care of it?
Elaine, you'll take care of it. Make sure that Mark gets that.
There you go.
Okay, I'm back. I don't know. Somehow my phone kicked me out, so I missed all of that.
So Mark just asked to make sure, let him know where you put the Dave Rawson presentation.
Right. I will. I'm pretty sure I actually have all your emails now that you've logged on to this. I'll check. If you don't get it, I'll Mark, just email me, john@drviviano.com, drviviano.com, and I'll get it to you. He's going to put it in a Dropbox folder. It's probably going to be big, so whoever I'm sharing it with, I'll probably have to create a shared Dropbox folder to put it in for you, right?
Okay.
Yeah. Okay, and so it's good. It's actually 5:04. I mean, we're having so much fun, we don't want to leave. Listen, guys, this has been great. Thank you very much. I'm very pleased, and hopefully you are too. We'll see you next Wednesday at 3 o'clock, and if you can't make it, you'll be able to go to our website and actually listen to it at your leisure. Okay?
All right.
Okay, thank you, guys. Ciao.
Next Wednesday at 1 o'clock, we've got the first presentation.
Right. Barry's doing a webinar at 1 o'clock next week. Thank you for reminding me, Barry. And actually, I'm doing a webinar, I think at 12 o'clock on Tuesday and 12 o'clock on Thursday for DSG. And the Tuesday one is nylon appliances, and the Thursday one is on appliance selection. So anyway, just for your information. So thank you very much, guys. Kudos, Joy. Please be safe. Be safe, everyone. Okay.
Bye, Barry.
All right, buddy.
Bye.
Hey, Mark, good to see you, buddy.
Bye. Take care.